It's such an honor and privilege to be here, and I agree with Dr. Axelrod. I'm glad it's just as a visitor. All right, so unfortunately the lights have to go down just so that your visibility here is optimized with the slides, but your handouts are in your packets. My presentation is pretty comprehensive, and we don't have the time to go over every single slide in detail, so just bear with us. We'll go a little bit fast through these, but I promise that the slides are meant to be very helpful and very complete, and I'm certainly accessible to you after our presentations are over and also by email. So we're all friendly, we're all nice, and we're here to help. Okay, so the title is so apt as a radiologist because we do use a looking glass, and nowadays with digital mammography we tend to use a digital looking glass, but I think what Dr. Axelrod also wanted us to get at is this idea of crystal ball, so looking into the future too, and so we will get to that a little bit later in this. Okay, so we are going to be covering, certainly, of course, background, why we are even talking about breast cancer, why is it still important. I want to make sure that you understand how mammography, screening ultrasound, and screening MRI fit together, because these are all legitimate screening examinations, but they're not all used equally. I want to also make sure that we cover screening versus diagnostic, because I think it's so important to make sure that you're scheduled properly when you are coming in for your breast exam with us. The next session will be covering more about screening mammography per se, because that continues to be the mainstay for screening for us, and there are multiple reasons why that will always be true, some version of mammography. I want to walk you through what you might experience when you actually come into an imaging facility, whether it be ours or anyone's. That's a quality institution or quality facility. I'll also give you some visuals, because as a radiologist, I have the extra luxury of giving you some pictures. And so it'll help you come into my world a little bit so you have an idea of what we were seeing, and I'll explain a little bit about that. I also want to make sure that I'm going to say this probably at least 3 times in this talk about how important prior films are when they exist. When it's your first exam, then we'll do that as your first exam, but whenever you've got prior exams and you're switching facilities, do get them. It behooves you, helps you, and it helps us. I want to also make sure that I say this at least a couple of times, that recall from screening does not mean cancer. I know that it can really strike fear in many hearts, and that's normal because you don't know what the outcome's going to be, but it does not necessarily mean cancer, and I'll make sure to cover that again. And then as we have time, we'll cover breast density, 3D mammography. A lot of people are talking about that and asking about that. Make sure we also cover clinical and breast exam, and I think we'll be covering that a little bit later as well. I don't think we'll have time for the others, but again, I'm accessible to you for questions. Now, why are we still even talking about breast cancer? So breast cancer continues to be the #1 for new cancer cases, #2 for cancer-related mortality. Okay, so this is an audience response. Now I can't see the clock at all, Rachel, so I have no idea how I'm doing, and I can't see anybody's eyes. This is so unfortunate. Okay, can men develop breast cancer, true or false? So please go ahead and answer true or false. You can't say unsure here, Rachel's trick, so please commit. All right, here's your timing. 28 seconds left. What is it? Just go to 20, and can I just, okay. All right, great. Okay, good. All right, so breast cancer in the United States. So it is still the most common cancer after non-melanoma skin cancer, and it's the most common new cancer diagnosis. But for mortality, so everyone talks about how it's second to lung cancer, but you know what? For women under 60, it's actually the #1. So this is a lesser known fact. This is not information to strike fear, it's just information to inform. But this is one of the reasons why we continue to talk about this for women who are younger. We talk about the statistic of 1 in 8 American women will develop breast cancer, and as someone who's a very hopeful person and an optimist, that still means 7 out of 8 women won't in their lifetime, okay? So to put that into perspective, but part of the problem here is that we don't know exactly which women will and which women won't. And by definition, just by virtue of being female, and as we age, we continue to be at risk. So again, information to be informed, but not to be scared. And it turns out that absolutely men can get breast cancer, about a rate of 1 to 100. So for those of you who answered correctly, you're right. For those who didn't, now you know. And so that's important for men to realize that it's possible, not probable, that if they do have something that seems suspicious, they should come in, not be too panicked, but not exactly ignore it either. Okay, so this is a slide that I think is important. It turns out that there are lots of extra statistics here that didn't make it into the transformation of this to this particular PowerPoint, but I think the main piece of data that I want you to see here is that for women who are in the 40 to 49 age group, it turns out that the number of cases of invasive cancer, so that means cancer that's broken through the milk duct wall, but still locally present in the breast, so localized disease. So the number of women who are in their 40 to 49 age group is about 21% for this particular year. The year before that, the data was a little bit higher. And the reason I mention this, and I'm going to mention this again, is because many of you may be aware of something that happened in 2009 that continues to really have repercussions now. And it has to do with the concept and the whole debate about screening women in the 40 to 49 age group. The whole debate about every year versus every other year is another topic entirely, but they're related but still slightly independent. So I just want to bring your attention to the fact that women in their 40s, which includes me and many of you, this is not an insignificant number. So the idea of not screening these women at all when we know that it can really make a difference, especially since they talk about this particular age group as having the most potential life years to lose. Again, I'm not trying to create panic, but just to inform. And this is a graph that's useful because this helps to illustrate how the risk of breast cancer is really small way down here in the 30 and under. And then it starts to go up. And the reason why we continue to recommend annual screening mammography starting at age 40 is because there's a little uptick that happens at the age of 40, and then it continues to go up after that. And the reason why we recommend annual is because if you're going to do the test, let's do it right. And the optimal way to do it is annually, and it has to do with trying to really average out and catch as many cancers that can be caught without over-screening. And so this is a concept that's a little bit difficult in some ways and yet so simple in others. I like to include this slide because this is important. We've had data about white and African American for a very long time, but it's the other minority groups who have only been recently started to be collected. And so, this is America. We've got an incredibly and wonderfully diverse population. The only way to really make sure that all the wonderful research that's being done for cancer cause, cancer treatment, cancer prevention, how are we going to make sure that all of this can be really applied to all people? And that's it's important to make sure that all people are included in the data. Okay, so breast cancer screening, about 3/4 of new cancers are detected by mammography. 2/3 of new cancers are early stage and treatable, and we're very happy about that. That's the benefit that screening has provided, because at screening we're finding cancers at a much smaller size than anybody can possibly feel. And we like it like that. Not that we're trying to wish cancer on anyone, but if it's going to be present, we want to be able to find it, and that's what screening allows. We know that randomized controlled trials have shown the benefit of regular screening for early detection. We typically talk about the 30 to 40% range of decreased death rate in those who are screened versus those who are not. So that's a number that you will hear and read if you read the articles. And the whole idea of early detection to allow for more effective treatment and better outcomes, I know that my colleagues will be addressing that as well. I want to make sure that you understand screening. So again, screening mammography by definition means that you have no lumps, bumps, complaints of any sort, no skin or nipple pulling in, no nipple discharge, anything that would be worrying you or your clinician. So that's what the definition of screening would be, a patient who is not at all symptomatic in any way. And so mammography, ultrasound, and MRI are used for that. Here are just some schematic images. So for those of you who have had a mammography, you might look like this when you come in for the mammography. I'll go over this a little bit more. This would be an example of someone who's getting an ultrasound. This might be the technologist or the radiologist coming in to check images after the technologist has acquired them. So sonography, US, so these are all terms that are used interchangeably for ultrasound. And then this is what you would look like if you're getting a screening MRI. So this is not for everyone. We do use it selectively, but I just want to mention it because it is a screening test as well. Now, I really have trouble seeing, but how many of you are aware that something really dramatic happened in 2009 for screening guidelines? Okay, all right. So I actually find it heartening that a lot of people don't know, but in a way it's also not great because it also might mean that whatever you're being told by your primary care physician or otherwise, depending on what they're saying to you, it may not necessarily be giving you the whole perspective. All right, so and All right, so this is a teaser. All right, clinical breast exam and breast self-exam are these. So clinical breast exam is the exam done by your physician. So my colleagues in surgery, medical oncology, primary care, GYN. So that's the clinical breast exam done by a licensed healthcare professional. It could also be nurses and PAs. So is that exam and breast self-exam, are those still important even if you're getting screening mammography? So I'd like for you to answer this. Again, you have to commit true or false. What do you think? Okay, excellent. Thank you so much. This is really, really important, and I'm so glad that you got this right. And it has to do with it, even if you're getting screening mammography. Remember, when we see you for screening mammography yearly, we're seeing you once a year. Okay, when you're getting your clinical breast exam by a clinician, you're getting that maybe once a year, and if you're seeing more than one or one more than once, then however many times that equals out to. But you live with yourself, and without examining yourself every day and being kind of a little panicked about it and a little bit overly obsessive, you can be checking yourself periodically, and the idea is that cancer doesn't obey anybody, does it? So it's not like it's asking our permission to start to grow. And so should you have something that's actually forming in between mammography, you want to be attuned to that. But remember, and I got to say this at least once, there's so many benign things going to happen at any time, and no matter what anyone tells you, benign things are always going to be more common than not benign. So again, don't panic. Don't be terrified. This is just information. So I'm really glad that you got this right. So let's just repeat now. So I want to make sure that we are setting the record straight again about what we believe, and it's true for all of us here who are on the panel here, what we think are reasonable guidelines for normal risk patients. And that means patients who don't have the BRCA gene, like Angelina Jolie did, or strong family history, or something else that's adding on to your level of risk. So we still believe that yearly mammography starting at age 40, because that's where that risk has a little uptick, and to continue annually for as long as you're in good health, because the whole idea is that screening will benefit you if you have a life that you're going to be living healthfully long enough to be able to benefit should there be something found. Okay, so we don't tell you when to stop. That's kind of a decision for you to make with your clinician, but we as radiologists will certainly see you as long as you want to come in. But that's the idea. So annual starting at 40 for mammography. The clinical breast exam and the self-exam, as you all just said, are still important in a particular routine, whatever is reasonable for you. So the rationale for screening everyone, we know about a lot of non-modifiable risk factors. And we also know that there are risk factors that are modifiable. That's why Dr. Axelrod and Rachel went through these questions to kind of pull your lifestyle habits. It's important for physical activity. About 2.5 hours a week would be good, moderately vigorous, as per the American Cancer Society. So this is one of those lifestyle risk factors that you do have some control over. Certainly your weight, your alcohol intake, some of these things are things that you can think about. So it's absolutely important to reduce risk where you can, but you know what? Breast cancer is multifactorial. There's no guaranteed method to eradicate all risk. And so the reason why we screen everyone is just by virtue of being female and aging, we are at average risk. So again, not to terrify you, but just to help put it in perspective why we really do still believe that screening everyone makes sense. And radiologists are physicians who are also called breast imagers or mammographers. This came up before the talk. So you'll hear different terms to refer to us, but we are not only interpreting and managing the imaging findings, but we also perform the needle biopsies, preoperative needle localizations, and the consultation regarding imaging, what's appropriate, and also how to manage what we see. Our technologists are the dedicated, I think all women, yes, who are acquiring the images, and so we work closely with them, and obviously their work is very, very important. So mammography is the best screening test for early detection, even if other tests are recommended for you if you're higher risk for some reason. Radiation exposure, people often ask about this. A screening mammography is comparable to about 1 to 2 months of background environmental exposure. So if you're living at higher altitudes like Colorado, for example, then you're already naturally getting a little bit more than that. But we absolutely do believe that this is safe. And remember, we're patients too, so we get mammography just along with you. All right? And the compression, why is it that we have to squeeze you like that? I know people ask that all the time. Well, we need to be able to see through the breast without motion. We're trying to minimize the amount of radiation we need to get excellent quality images because we're only as good as our imaging, right? We're radiologists. We're also trying to make sure that we're minimizing motion because we don't want to miss something and we don't want to have the motion making something up. So there are lots of reasons why the compression is important. I just want to add that if you do find it really, really difficult and intolerable, Motrin, Motrin or Tylenol, something like that, you can certainly take on an as-needed basis if you need to. And again, the annual interval is really what we feel is optimal because it's trying to catch as many cancers as possible without over-screening. So this is what you might look like when you're getting your mammography. This is when the breast is being squeezed like this, and then this is when the breast is being compressed like this. Rachel, you're going to want to give me, right? But I can't see you either, so you might have to say something or nudge me. Okay, and then when we're at the workstation, so nowadays most facilities are going to be digital mammography, so this is what we might see at the workstation. So if you're at a facility where you can actually go and see what your mammography looks like, then by all means ask. There's no reason why you can't, and this is a way to look at yourself that you can't any other way. So be curious and take a look. You certainly want to look because you want to get an idea of how dense your breast tissue is, and let me go over that a little bit more. So these are schematic images. So this is an example looking from the side. So here's the nipple. And then these are areas of fibroglandular tissue. So structural components and the milk duct structures that together will create some whiteness on mammography like this. And then fat will always be seen at least a little bit just deep to the skin. This is the skin, this is the rib, this is the pectoralis muscle. So we're always going to see some fat, but the proportion of the fibroglandular tissue that's white and the fat will be highly variable. So every single one of you who has breasts will have a unique image. Nobody else has a mammogram that looks exactly like you. Now, I want to go through this because breast density is a pretty hot topic, and yet it can be so confusing if no one explains it to you fully and correctly. So we think of breast density as 4 different categories of, or rather rating scale in a way. So this would be someone who has predominantly or completely fatty breast tissue. So you can imagine something growing here or here would be easier to see than in someone who has all this whiteness, because little cancers are usually going to look white too. So these are the 2 extremes. These are the terms that we use when we dictate our reports. So if you see your mammography report, I know more patients have access to their own reports nowadays, but be careful with that power. All right, so if you're looking at your own mammography report, you'll have some wording that's describing your breast density. So there are 2 reasons why breast density is important. One is because there's that potential for making it harder to see a small cancer. And 2, some people do believe that having very dense breast tissue in and of itself can slightly elevate your risk of developing a breast cancer. I would say the first problem is the more significant problem for us and the more immediate problem, and I would say let's not worry too much about the latter part. And I can certainly talk about that to any of you in person if you're curious. I also want to mention that how your breasts feel don't tightly correlate with how your mammography looks. So if you're wondering about your breast density, you really need to be asking about your mammography, not just how your breasts feel. And I know that can be confusing just because the terms often used for the clinical exam about dense tissue, fibrous, fibrocystic, all these terms that are used interchangeably, it might make you think and assume that you've got a dense mammogram, but not necessarily. So do inquire, and you're going to want to know. These are some quick examples of the categories of findings we look for. If you're reading your own mammography report, as I said, be careful. If you're seeing microcalcifications, mass, asymmetry, distortion as words in there, don't assume anything bad, because these are neutral terms. These are categories of findings that we're looking for, but everything has to be understood in context. What do we already know about you before? What are we calling new? And then how are we characterizing it further? I'm not trying to train you to do what I do, but just to help desensitize you just a bit with some of the terms that you might hear as you're going through your screening process. So this is just a quick graph explaining a couple of important concepts that might seem very complicated but are actually kind of simple in a way. So breast cancers are not all the same. We would be so lucky if they were all exactly the same in how they look and how they present it, but they're not. And so we've got cancers that are very fast growing, and so someone who's getting an annual screening mammography, if you think of these arrows as indicating the annual interval for exams, that person may not necessarily benefit to the same degree as someone who's got these more moderate growth rates. And then if you've heard about the so-called tumors that never would have harmed someone, they're referring to this type of tumor that's so slow growing that it may still not have even spread outside of the breast by the time the patient's deceased from some other cause. But you know what? We can only go so far with figuring out which is which with imaging, and that's not anyone's fault. There's just so much overlap between different types of cancer and different tumor biology. So it's important to understand that these are some concepts that you're here being thrown around about breast cancers. All right, so the recall from screening, do not panic. This does not mean you've got breast cancer. Okay, about 10% of patients will be asked to return for additional evaluation. That might be additional mammogram images, maybe some ultrasound, maybe clinical breast exam by one of us, and putting it all together and figuring out something, what the answer is. And then of these, about a quarter might need a biopsy, and then a small percentage of those will actually have cancer. It doesn't mean we don't know what we're doing. It just means that we're managing everything we see. And when you think about it, we're not even born with breasts. So you think about how common benign things are in the population. Remember, they have to start at some time, right? And so as we do our work, we're managing what we see and doing what we feel is appropriate. And we self-audit like crazy. No other medical field does that. So some people think of finding cancer in mammography as analogous to finding a needle in the haystack, but at least the needle and the hay are made of different materials. It's a little bit more like looking for Waldo. All right, so he's down here. But it's even harder than that, because our images are black and white, all shades of gray. All of you are different with your Waldo images. And you can always form a new pseudo-Waldo that, again, we're managing what we see. So make sure you get your prior films whenever they exist. Do submit them. It's going to be good for you. And I want to also just bring your attention to the breast density legislation. Is anybody aware about this breast density legislation, the notification law? Anybody who's had mammography in the past couple of years will have gotten something on their mammogram report if you have dense tissue. So the RU Dense website is a good place to understand more about that. Digital breast tomosynthesis is one of the modalities that we are very excited about. It's going to let us look through dense tissue by thin sections, and we know for sure that it really makes a difference. A little crystal ball image here looking into the future. There is research about a fast MRI exam, but that requires a contrast injection. So I would imagine a minority of you might have had a breast MRI in the past. And then contrast-enhanced mammography is also a different type of modality that some people are excited about. All right, so mammography is still the most important screening test for us all. It really is still the mainstay, and there are a handful of reasons for that. We absolutely do believe in annual screening mammography starting at age 40. And I would say, you know what? If you're going to do every other year, starting at 50 and going to 74, better than not at all. But if you're going to do 40 and going annually, that would be ideal. But whatever you choose to do, it's your choice, as long as you feel that it's an informed decision. But by all means, make sure that you're checking yourself and you're getting clinical exam along the way as well. And I think that's a reasonable way to make sure that all these detection methods are going to be working together as best they can. Ultrasound and MR may be appropriate for additional screening depending on your risk factors, but they don't replace mammography. So breast cancer is still a significant disease. 3/4 of new cancer diagnoses are women with no obvious risk factors other than being female. And this is just information. About 22% are women in their 40s. So doesn't it make sense to screen us? I think so. There's nothing particularly magical about this age 50. It's not as if it's a stepwise incidence curve there. And there's a wide range of normal breast density for every age group. Be curious about your own. Breast cancer has many different appearances, part of our challenge of our job. And the reminder about submitting prior exams for comparison. We don't yet have a 100% reliable prevention or a universal cure, but we do have screening, and the screening works really well. And I'm actually glad that we can screen for breast cancer at all, because you think about some cancers that you actually can't screen for. And the purpose of annual screening really is to find cancers as early as possible for the best chance of cure. So these are my 3 kids. These are their particular reactions looking at mammography through the looking glass in their hands. And then this is a crystal ball, because again, we're trying to talk about what we know now and what we do now, and also a glimpse into the future. So thank you so much for your attention.